Last presentation of this session is a case report on disseminated juvenile xanthogranuloma. I would like to invite Dr. Palvisha Qadri. She is currently resident at Aga Khan Hospital.
Assalamu alaikum. To present my case in the presence of such big names is a bit embarrassing, but anyhow I have to do it. So I am Dr. Palvisha Qadri, it's not Qadr, and I'm a resident, year 2 resident dermatology, Aga Khan University Hospital, Karachi. And this is a case which presented to us in our outpatient clinic, and the attending with me was Dr. Najmus Sahar, who is serving as assistant professor in Aga Khan University Hospital. And she gave me the opportunity to present this case. So I have nothing to disclose and I have no conflicts of interest. I will be going through the case and then clinical and histological presentation, the discussion and the conclusion. So it was a 7-month-old baby boy who presented to us with reddish brown eruptions all over the body for 3 months and erythematous rash in the napkin area, axilla and neck folds for 1 month. The spread was craniocaudal and it spared the extremities, especially hands and feet, and it was itchy at times. He was prescribed topical clindamycin, tretinoin and antiallergics before coming to us. Rest of the history remained unremarkable. Cutaneous examination revealed multiple reddish-brown nodular lesions which were firm to touch, immobile, involving the head and neck area, trunk and girdle, and it spared hands and feet. Accidentally, we also found some erythematous, well-demarcated scaly plaques, much like those of the seborrheic dermatitis, involving the groin, axilla, and neck. So the initial lab workup, including the chest X-ray also and the laboratory blood tests, were all within normal limits. So this is how our patient had presented. You can see the nodular, firm to touch, and widespread lesions. They were nodular lesions and they were not scaly at all. Although the rash present in the groin and the neck area was erythematous and scaly. So we advised a skin biopsy. Here you can see that the lesions were based in the dermis and they were going up in the epidermis, plus they were also going down in the subcutaneous tissue. And the lesions were composed of sheets of histiocytes exhibiting grooved vesicular nuclei and pale eosinophilic cytoplasm. Teuton-like giant cells were also present, which is obviously the hallmark of the disease. And they were also scattered eosinophils, lymphocytes, and plasma cells. Here you can see a closer view of the histiocytes with multiple nuclei. We also advised immunohistochemistry, which came out to be positive for CD4 cells, Ki67, and also CD68. So we ordered additional labs and investigations to exclude any systemic involvement. And fortunately, all of the workup came out to be normal. So it was skin-only involvement of juvenile xanthogranuloma of the disseminated type. So we reassured the patient and the attendants, and we gave combination of an antifungal and a mild steroid for the folded rash. And we called him after 1 month for follow-up. So JXG, which is juvenile xanthogranuloma, is a rare, benign, proliferative histiocytic disorder of dermal dendrocytic origin, and it is the most common form of non-Langerhans cell histiocytosis. Typical lesions are yellow to red papules, plaques, nodules, and most often on the head and neck and upper trunk. Extracutaneous or systemic JXG is extremely rare, and it occurs in around 4% of the cases. Ocular JXG may be there in the absence of the skin lesions. The diagnosis is usually clinical if it's presenting the usual way, or otherwise we can get skin biopsy and immunohistochemistry done. So this is the literature review. Some of the cases are reported, and so far only cases are reported with such type of the lesions, and most of the cases were either a sequelae of some systemic Langerhans cells histiocytosis, or after the treatment of any other histiocytic disease. So as I said that none of them occurred de novo. So our case is unique first in terms of the number of lesions and widespread distribution in a 7-month-old child, plus it also occurred de novo, and there was no any other involvement of the systems. No such case has been reported from our part of the world so far, to the best of our knowledge, and we are in the process of reporting this case in a good journal, inshallah. So to conclude, JXG is rare but significant disorder of childhood and carries a worse prognosis, especially when associated with systemic involvement. So early recognition is the key to successful management in order to prevent long-term irreversible complications. Thank you.